So Ajay, I could be horribly wrong.
In what respect?
I see 24 so far.
Well, it's still 2 minutes to go.
Yeah. Well, Kaushik did this all this time. This is the first time Preetha and I am managing it. Let's see.
This is also going out live on YouTube?
Yes.
Okay.
I will have to make a slight correction in terms of affiliation. I was formerly with the FLA County Department of Public Health.
Okay. That's well in time. So I will ensure that correction is made. Hello. Okay. So it's 7:30, and I think let's begin this webinar series. So let me extend a very warm welcome to all participants to this 16th Consumer Pyramids Research webinar. So this webinar is a platform for researchers to present their work based on the Consumer Pyramids Household Survey database. We have been privileged in the past to have many wonderful papers presented over here and excellent debates and discussions. Many of the papers going ahead to be published in distinguished journals. Today we have a presentation by Dr. Ajay Shah. Ajay Shah is a graduate from IIT Bombay and earned this doctorate from the University of Southern California, Los Angeles. He has varied interests. He's been a researcher of lots of interests. So he initially played a major role in reforming India's financial markets, financial institutions. That was the big work he did in the 1990s and a little later than that. Then he joined the Ministry of Finance as a consultant and played a big role in public policy, and has been an author of 3 books, ranging from public policy, financial markets, and even national strategies. His most recent bug is health services associated with public policy, and also climate change. His paper today is on self-reported health as captured by the Consumer Pyramids Household Survey. This is very interesting. This is the first paper based on health in general. Like Ajay in his paper has also explained that much of the interest in India on health is around infant mortality and associated things. And there isn't much work done on health in general across the entire age spectrum. So Ajay kind of addresses that issue. Ajay has also worked earlier. He was the earliest worker on the CPHS database when it comes to mortality. And Ajay just informed me a short while ago that Naman, who's with us today as well, Dr. Naman Shah, played a role in that as well. Ajay did estimations of mortality and even excess mortality from the CPHS database, exploiting things in the database which were not clearly apparent. And then many others have gone to do research. Anup Malani has done research and presented on this webinar, and also Arvind Subramanian and his co-authors. So Ajay is extending his work on CPHS database now in the area of health across the age spectrum, not only infant mortality, not only narrow things about morbidity, but about the entire age spectrum. So that's a very, very interesting paper. This is going to be a great paper, therefore. We really look forward to this because CMI is very interested in health in a big way. And just to let you all know that there is a nice research work happening also with Manoj Mohanan in Duke University on mental health. But that's for later. Right now, the focus is on self-reported health, research done by Ajay Shah. And very warm welcome to you, Ajay, on this webinar.
Thanks, Mahesh. I'm happy to be here.
Thank you. And let me also extend an equally warm welcome to Dr. Naman Shah. Naman Shah, we have disturbed you very early in the morning. So this is very kind of you to join this show so early in the morning. He is in Navajo Nation in the US right now. Naman is an NIH-trained physician scientist. His professional interest is in improving public health and healthcare systems. He has lived and worked in rural India, and that's a big thing which will be relevant in his comments on Ajay's paper today. He has been on the Indian Council of Medical Research National COVID-19 Task Force. So that's also very interesting. And he was on the Los Angeles County Department of Public Health. So that's Naman Shah. And I look forward to this presentation by Ajay. Ajay, you have 1 hour to make your presentation. And after that, Naman, you have 30 minutes to make your presentation or your discussion on this. And audiences can type in their questions if they have any. Ajay will answer those at the end of this session. And that's it. You can ask your questions as and when you like, but Ajay will answer it in the ending. So we have a fairly good house. So Ajay, over to you for your presentation.
Thanks. I'd just like to do a share screen. So my slideshow will appear. Can you see it?
Yes.
Okay, great. So thank you everybody for your interest and involvement in this seminar. Mahesh precisely articulated the concept of what is going on here. There is an important new piece of measurement going on in the CPHS in the field of health. CPHS opens up new avenues, and this is a first paper exploiting self-reported health. So let me get started. We are all researchers, we are social scientists. We would like to understand more about the causes and consequences of health. We would like to know what shapes health, and we would like to know that we'd like to know about the implications that health has for everything else in the life of an individual, in the life of a household. In the literature, there are exactly 3 pathways through which you could measure health. One pathway is to do medical tests. So hypothetically, you could meet up with people and take blood samples and do detailed medical testing, and that would yield definitive answers. For example, an HbA1c tells you about the blood sugar in that person's body in a way that the person will often not know herself. The second pathway to measuring health is to look at mortality. And this is also a great line of attack, that how are people dying? What do we know about the death process? It teaches us something about health. The third pathway is to just ask people, how are you feeling today? Are you feeling good today? And this is the measure that is called self-reported health. The CMI CPHS database is a foundation for the second and the third kinds of research. We can study mortality and we can study self-reported health. And this paper is our first take on opening the database and looking at what's going on in the self-reported health. The simplest version of the question is, are you feeling well today? This is what CMI is doing. Alternatively, there are other researchers who have used a 5-point measure where the person is asked, how do you rate your health today? And the answer is something 1, 2, 3, 4, 5. Okay, so these are the 2 kinds of self-reported health measures. Now, the moment we think about this, it is apparent that there are limitations in this measure. There is an inevitable psychological filter. Some people are more stoic than others. Some people just normalize ill health. As all of us get older, we get used to certain infirmities and we say, no, I'm fine, everything is great. Well, actually, it is not. So there are undoubtedly limitations of this idea. But an extensive literature has emerged, and there are many useful things that can be done with SRH. I'd like to draw your attention to the paper. In the PDF of the paper, you will see us showing a clear summary, a literature survey of the field of SRH and 3 kinds of limitations of work done using SRH. So we should all be mindful of the limitations of SRH, and there are opportunities to do useful work using SRH. It's easy to criticize SRH saying this is just a subjective measure, but a nice feature in this field is that it actually correlates with objective health measures. So for example, when you study death, it does work out that people who self-report themselves as unhealthy are more likely to die. Similarly, there's a whole bunch of linkages to socioeconomic status where there are 100 papers all over the world where SRH lines up nicely, and you will see in this paper also, SRH lines up nicely. So we need to make our peace with the idea of asking people, are you feeling well? For an analogy, consider the happiness literature. We ask people, are you feeling happy? And that makes me even more nervous than, are you feeling healthy today? But there is a lot of value in this information of asking people, are you feeling well today? In this audience, I don't need to belabor the CMI CPHS. This is an important new panel household data set in the world. CMI measures 170,000. CMI tries to measure 170,000 households 3 times a year. There's a wide variety of information about individuals and households. And this is an opportunity to do a lot of novel research on the causes and consequences of health. As Mahesh emphasized, the present Indian health literature is quite limited. NFHS has an emphasis on measuring women and children, and there is really very little other large-scale, high-quality data all over the country. There's very little panel data in the country. So this is just a remarkable moment in the history of the Indian health literature to start establishing the basic foundations of a health literature. And we think of this paper as the first paper of establishing basic facts about self-reported health. There are innumerable downstream ideas where this can go. I will allude to some of them in the talk today, but all those downstream papers will need this first foundational paper because we're establishing certain basics. Now, in this paper, we use only 6 waves of data. Again, in this audience, I don't need to explain what is a wave. Each time CMI spends 4 months meeting all the households of India, that's called a wave. And there are 3 waves in 2018 and 3 waves in 2019. We consciously chose to do only these 6 waves. Why is that? We wanted to avoid the pandemic because actually there are innumerable papers to be written on what happened to self-reported health in the pandemic. Okay, in the first wave, in the second wave, when Omicron threatened people, when there was a lockdown. There are innumerable lines of research. And in all that, we as researchers are going to need to say, how is this different compared to double quotes normal times? In this paper, we're trying to talk about normal times. Similarly, we wanted to avoid 2017 because it will allow us to write papers about demonetization. So in November 2016, you get the demonetization shock. There was a whole array of things that happened in the labor market, which many people have already written papers about. And it would be interesting to play that through into health. So that's also a contaminated period with very large developments going on in the economy. So we found this sweet spot. 2018 and 2019 are normal. We think of this as a baseline description of what is health in India like under normal circumstances. And then these grand events can be analyzed in terms of figuring out how those events shook the system away from the baseline. Okay, in this data for 6 waves for 2018 and 2019, we find there is 170,000 unique households, 736 unique individuals, and we treat this as unbalanced panel data that gives us a data set size of 3.5 million individuals. So if you think of a record as one individual being asked a question once for how are you feeling today, then this data set has 3.5 million rows. Okay, so it's a nice bulky data set where we are seeing a ton of information in the baseline of how India works. In all this, we use the CMI concept of homogeneous regions as the pathway to thinking about locations. Once again, in this audience, I don't need to introduce this from scratch. It's a beautiful cutting up of the country into 102 subnational pieces. On average, 13 million people each. On average, a small European country is one HR. And I am fascinated by the usefulness of the HR concept. It's more useful to study one HR at a time rather than look at one state at a time. And most data sets don't allow us to look at one district at a time. So the HR is a nice sweet spot within which we can look subnational in India. And we don't have to think that Maharashtra is one homogeneous thing. We don't have to think that UP is one homogeneous thing. We look at one HR at a time. So now let's turn to what this data says and what it teaches us about the health of the people of India. So first, for the grand fact, the overall average ill health rate is 3.25%. Okay, so if you ask 100 people, are you feeling well today? 3.25% of them say, no, I'm not feeling well today. Okay, and just doing arithmetic, that maps to 44.4 million individuals, population estimates, who are unwell on any one given day. Okay, so that's an interesting fact to know about India. On any one day, 44.4 million people are not well. And similarly, you do this arithmetic, what it tells you on average is that in a year, a person is unwell for about 12 days a year. Okay, so it was a surprise to me because I personally consider myself unwell for about 1 day in 5 years. And so I was surprised that I'm much healthier than the main population that we see in this data set. The first picture that we should look at is how does the ill health rate vary by the age structure. So on the x-axis, we put the age structure, and on the y-axis in log scale is the ill health rate. And as we would expect, there's a nice U-shaped pattern. Kids are unwell, and then people become dramatically unwell as they get older. Above age 70, 30% of the people are reporting, I'm not feeling good today. Okay, and the moment you think about this for a moment, you will see there is a survivorship bias problem. So there are truly unhealthy people at age 40 and 50 and 60 who just die, and they're not around in old age to report to us that they're not feeling well. So by the time you're looking at ill health of older people, it's actually a survivorship problem. It's a combination of a health process and a death process. So we need to think more carefully about how to interpret ill health rates when it comes to old people. And it's also interesting to see that the lowest value in this data for people aged 20 to 24 is about 0.5%. So 0.5%, 1% of 365 days a year is 3.65 days a year. 0.5% is about 2 days a year. So on average, the healthiest age subset of the population is age 20 to 24. And these people are feeling unwell about 2 days a year. So this gives us a flavor of the basic facts of this data set. So now we go a simple two-way table. On the columns, we have simplified the age structure. So from age 10 to 34 and age 35 to 49, the ill health rate is a bit homogeneous. So we club these together. And the columns have just been reduced to 6 age groups. And once again, you see the overall averages in those as the first row here, which is exactly the same as the picture that was shown above at a more fine-grained age structure. But we now split it by income and we split it by region. And there are some interesting findings here. Normally, you would expect that as people get richer, they should be more healthy. Okay, and that does work out. For example, at age 10 to 34. So look closely at age 10 to 34. The poorest people have an ill health rate of 1.23%. And then it monotonically gets better as you get older. Sorry, as you get richer. And the richest quintile has an ill health rate of 0.63%. Very nice. But that's not what you see at the age group like 0 to 4. And that's not what you see at an age group like 60 plus. It's not monotonic, it's complicated. Okay, so we just want to note this in passing right now and leave this as a subject for further research. I suspect there are selection bias effects going on, that when you have age 0 to 4 with poor people, they're likely to die. Whereas age 0 to 4 with rich people, they're likely to live. So the infant is around, and then the parents are able to say that this child is not feeling well today. Whereas when you get to poor people, it appears that the child is healthy. There may just be a survivorship bias going on. Okay, next I turn to region. The striking fact of the region data is the difficulties of the Northeast and the difficulties of the East. Okay, so you will see more maps, and some of our simple preconceptions about Bimaru states don't play out. The worst places in India, once again, let me look at age 10 to 34. The worst places in India are the East and then the Northeast. Sorry, the East and the West, and then the Northeast, and then the North. Okay, so it is true that the South is significantly better than everything else, but for the rest, it doesn't fit some of our simple preconceptions about the age structure of what are the bad parts of India. And I'm going to show you maps in a moment where you'll see these things more clearly. So there's powerful variation by age, there's powerful variation by income, and there's powerful variation by location. So far, I've just shown you some summary statistics, and we're going to turn it into some logits in a moment. Let's put this on a map. So here again, this is a simple unconditional map. In every homogeneous region, we just ask the question, what's the ill health rate? It's the overall average ill health rate, not controlling for age structure, not controlling for income, but showing you the variation by location. And some things jump out here. Kerala does pretty bad. South Kerala does particularly badly. Uttaranchal does badly. This HR in Haryana does badly. I apologize, I don't know the name. So for everybody in this room, I am in the process of making a poster size map, all the HRs with the names inscribed. So if you want this, please send me email. I'll give you the PDF because I've yet to memorize all the 102 HRs and the districts that they correspond to. And we see a chunk of difficulty in this part of Bengal. More generally, Bengal and Assam are doing really badly. Okay, UP is a giant state, and UP is actually heterogeneous. So there's a part of UP here that is doing reasonably well, and East UP is doing reasonably badly. So this is again a reminder of the importance of using HRs rather than states. States in India are just too vast. UP is a gigantic country. We should study one HR at a time. So we said that the three main sources of variation are age, location, income. And here this is an unconditional distribution of the ill health rate, showing only the variation by location. We will come back into thinking about location in a somewhat more rich way in a moment. How do we dig into this data deeper? And this is a proudly non-causal paper. We believe the first steps in all science are description. It's very important to describe large-scale, high-quality, longitudinal data well, and there's enormous insights to be obtained by double quotes, mere description. How would we go further in this? So in this paper, we're going to do 3 logit models. We're going to fit logit models where the left-hand side is the 0, 1 variable saying, are you feeling well today? The first is a simple logit on a bunch of covariates. You will see what those covariates are. In the second one, we introduce location fixed effects. So there are 102 dummy variables for the 102 homogeneous regions. And then model 3 is S.V. Subramaniam's pet peeve. He's the co-author that got added to this paper because he fought with us about this paper. And he emphasized that it is incredibly important to have the SCS coefficient, the income coefficient, vary by location. That is a very important set of insights into the world, and he was absolutely right. And that's the third piece that we do in this paper. And we will show you these results and their interpretation over a bunch of slides. So let's start at some broad facts about these model 1 to 3. Once again, model 1 is a simple logit model, 3.5 million observations and a handful of household characteristics and individual characteristics as explanatory variables. There is a time fixed effect because we don't want macroeconomics and seasonality to kick this around, but there's nothing else. Okay, so just note the Bayesian information criterion here is about 804,000 and the log likelihood is minus 400,000. Okay. Now, when we introduce the HR fixed effects, we've introduced 102 new free parameters. And look at what a gigantic impact it makes on the log likelihood. Okay. In return for 102 free parameters, we have gained some 36,000 in the log likelihood. And there's a huge gain in the Bayes information criteria. So model 2 is clearly vastly superior to model 1 and it is shouting at us saying location is incredibly important, is really very, very important as compared to all the other simple standard socioeconomic explanatory variables in model 1. And then we introduce variation in the income coefficient by homogeneous region. So now we have 102 more free parameters where all the income coefficients are allowed to vary on a per HR basis. Okay, and here we do get further gains in the log likelihood and further gains in the Bayesian information criterion. So if you were just going to be formal and use the Bayesian information criterion, then model 3 is indeed the best one. But the gains in model 3 as compared to model 2 are small. In passing, I want to say Renuka always laughs at this table and she says that most economists would do an HR fixed effect and never take it seriously. And what we've done in this paper is to take the HR fixed effect seriously. And it is so interesting. It is so rich with insight. It's a window into understanding India. And I encourage everybody on this call that we should not just mechanically do these controls. We should take interest in the findings because there is a rich story about India that we are able to discover by taking these coefficients seriously. Okay, so now I turn to the explanatory variables. There is the usual collection of gender, religion, caste, education, which are the explanatory variables that we use in these kinds of models. And the curious finding is between model 1 to 3, there are many things that are significant in model 1, but then they go away or they become less important once location is in the fray. Naman, you complained about this once. These are no longer logit coefficients. These are odds ratios. Okay, so when in Rome 2 as Romans do, and these are all odds ratios. So you see some pretty large odds ratios. For example, non-Muslims have an odds ratio of 0.75, but it pretty much goes away once you control for the location, okay, and so on. So you look at caste, OBC, SC/ST. These are very large odds ratios. Upper caste is the reference category. Not stated is 0.747. Okay, so people like me are very healthy, but all these things go away once you go to model 2, where you control for location. So location is incredibly important, and a lot of the explanatory variables on this slide, frankly, don't matter too much once you've taken care of location. So model 2 and model 3, yes, there are some things that are, statistically significant, but really the dominant thing going on is age, location. How do you visualize these model estimates? So there are 102 dummy variables for the fixed effects in the HR. There are 102 income coefficient values, and this is a large number of facts, and it's difficult to think about them. So what we do is we fix on an approximately model person. So we claim that a Hindu male age 35 to 49, SC/ST, class 12, rural, 13,000 a month. is roughly the model person of India as seen in this data set. And we predict the ill health probability for this fixed person across all the 102 HRs. Okay, so this is like saying that I'm controlling for age, I'm controlling for income, and now I'm only allowing the location effect to show up. And this gives us a new picture. This is the predicted ill health rate from model 3. Let's pause and think about interpretation. Earlier, I had showed you a picture of the variation of the ill health rate. This is just an unconditional picture saying, you want to know where people in India are unwell? They are in South Kerala, they are in Uttaranchal, they are in South Bengal. Okay, and this doesn't care about the reasons why. Is it because they are old? Maybe in South Kerala they are old. Is it because they are poor? Okay, whatever. There could be many reasons. Now we are at model predictions where we have controlled for income and we've controlled for age. It's the same person of the same age and the same income, but all around the country, there's a lot of age variation. At this point, you start thinking, is there something wrong with the place? Is this attributable to something about the place? Is there something wrong with Uttaranchal that holding the same level of income for a rural person, holding the same age, the person is unusually unhealthy in Uttaranchal. The person is unusually unhealthy in Eastern UP. Okay, so these are new findings. This is a story about ill health in India that is something specific to that place. Could it be that the healthcare of that place works badly? Could it be that the public health of that place works badly? Could it be that there is arsenic in the water in Assam, which is generating this bad ill health in Assam? Okay, and similarly in Bengal as well. Could it be that there is so much international travel in Kerala that this is a hotbed of finding new strains of infectious diseases? Could it be that there's so many religious tourists from all over the country who come to Uttaranchal that they bring the latest and greatest infectious diseases to Uttaranchal? Okay, we don't know these answers, but this map is our entry point into that kind of large-scale epidemiological investigation into the nature of health in India. What is it about the determinants of health, including both healthcare and public health, that are generating this map where we are holding the person constant, we are holding the age constant, we're holding the income constant, we're holding the education of the person constant, but there is such strong variation of ill health across these locations. Okay, now we turn to the role of income. I'm going to show you the coefficient of log income. So in model 1 and model 2, the odds ratio is lower than 1. I think richer people on average, overall on average, are healthier than poor people. And in model 3, it doesn't make sense because there is 102 different slopes for model 3. So what we're going to do is that for those 102 slopes, we will focus on a 95% hypothesis test for each of those 102 slopes. And just think of a simple three-way classification. Is it statistically significantly negative or positive, or you cannot reject the null of 0? And that gives us this map. Okay, so let's once again pause and think of the interpretation. Blue are the places with a double quotes normal profile that richer people are healthier than poor people. So I want to be very careful. This is a proudly non-causal paper, but even in expression, one should not erroneously imply causality. I'm not at all saying that if you made people richer through high GDP growth, they would get richer. I'm not bringing any treatment into the picture. I'm not saying that if you do a universal basic income or you do a welfare program and you make poor people rich, then they will become healthier. I'm saying that in an HR like this, like Saurashtra, richer people are healthier than poor people. Okay, we don't know why, but we know that after controlling for everything, richer people are healthier than poor people. For example, in Kerala, in all the 3 HRs, richer people are healthier than poor people. Okay, that's blue. Now, what's remarkable about the map is that only about half of India is blue. So in the previous table, I said that under model 1 and model 2, the overall average coefficient is in the correct direction. Richer people are healthier than poor people. But that's true only in about half of India. It's true only in 54% of the HRs. In the remaining 46% of the HRs, there are white regions where rich people are as unhealthy as poor people. Wealth does not help. It's a bit mind-boggling if you pause to think about it, that high income does not protect you if you live here. Rich people and poor people are suffering the same health consequences of being in that bad place. Okay, and the most amazing are the red parts where rich people are worse off in their health as compared to poor people. Okay, so this is another interesting, important finding, and this is a non-causal paper. We do not propose explanations. We're discovering facts. We're writing the first paper, which is opening a treasure of data and discovering some things in there for the first time. So we wish to say that this is a striking, interesting, and important finding. We have many conjectures about why this might be true, but actually whole downstream literatures are waiting to be constructed around these questions on trying to figure out what is going on. So I've already been babbling around these things. The ill health of the modal person varies a lot. And this takes us to epidemiology. Is it the arsenic in the water? Is it the pilgrims coming to Uttarakhand? Is it the public health? Is it the healthcare? Similarly, I've already talked about the geographical variation, the slope. Normally, we expect higher income ought to help. Higher income should be correlated with more knowledge, more nutrition, better housing stock, reduced exposure to disease vectors, and the ability to buy private healthcare. So I want to think about healthcare for a moment. Imagine that there was no healthcare at all. So everybody was in the same boat. There was no healthcare. When you got sick, you just crawled into bed and waited for nature to take its course. Even in that case, better knowledge, better nutrition, and better housing should help. So higher income people should be less unwell than poor people. How do you get to a red zone? Okay, so the only things we can think of are three candidates. Perhaps there's survivorship bias. Perhaps it looks like this because rich people live into old age and they're very unhealthy in old age. Perhaps it's diet. Maybe when we get rich, we start eating butter. Okay, and perhaps it's healthcare. Perhaps there is healthcare in some parts of India that is positively toxic. The healthcare is actually killing people. Okay, so many research projects are required that go drill into these conjectures and think more deeply about them. In this paper, we lay no claim to explaining these phenomena. We're here to discover these phenomena. We're here to show interesting, fascinating, important, fundamental facts about the health of the people of India, which is something that all of us in the field of health should take great interest in. So to conclude, SRH measured in panel data opens up a whole new set of opportunities to study the causes and consequences of health in India. In this paper, we've laid some foundations for this research program. We have some broad facts about SRH. We've got some knowledge about correlates from logit regressions. We feel that the main explanations, the main variation is explained in age, income, and location. And there are some remarkable phenomena going on with variation. We conjecture that mere economic growth will improve health in about half of India, and we're truly mystified about the remaining half. So my co-authors and I, Ila Patnaik, Renuka, Sane, and S.V. Subramaniam, we are grateful to you for your time and look forward to talking with you further about all these things.
Thanks, Ajay. Thank you for that very crisp, very clear presentation of your findings from this data. Many of them, of course, raise lots of questions. And I think that's what you intend to do over there as well. This is the first foundation of getting the facts across so that we know where to look next, what are the research programs to set in to understand why. In some places, income seems to matter. In some places, it seems to be inverse. In some places, it doesn't matter, for example. And there are many other things. So I think it's a very...
So may I just go one step further? Again, this is the perfect community in which we should be doing this conversation. These are broad facts over 2018 and 2019. A fine-grained exploration of these phenomena will require exogenous variation, plausible exogenous variation, and that will turn on innumerable natural experiments. And the beauty of the CMI CPHS is you are there measuring these things all the time. So there'll be some rainfall-driven variation of income, and suddenly you're getting a plausibly exogenous source of shocks to income. And there are paper opportunities to talk about how income causally affects health, and so on. So there are innumerable natural experiments going on in the world, and you are there day after day building this database. And so we can take this kind of research program and these questions and go drill into one HR at a time, one cyclone at a time, and obtain deep insights, which will shed more light on this data.
Yeah, sure. We will be there. We will keep monitoring and measuring, and hope more of your kind go dig into the data and find out what's going on over there. So there are a few questions, Ajay, but we will come to that after we hear Naman. So Naman, may I request you to kindly now give your thoughts on Ajay's paper?
Sure, and I hope we can just make this more back and forth and interactive, Ajay, rather than me speaking in a monologue for 30 minutes. So first, I think we're often trained, I think, in the social sciences and public health sciences to be more critical than appreciative. So I'd like to start with some appreciative thinking. This is my first introduction to really in-depth use of CPHS data. I think it's a phenomenal data source. I think this was really an interesting question that was asked. The size and panel aspect of the data design presents a lot of opportunities. And I thought you were thoughtful about the years you selected to avoid external shocks. Although, as you know, those external shocks could serve as interesting experiments in themselves. So in terms of the question asked about self-reported health, if you think about health as a 2x2 table between objective health and subjective health, obviously we all want to be in the quadrant of great objective health and great subjective health. I think, and they do often correlate. It's more interesting. I think we learn more when they don't correlate. Then you get to ask why. Why do you have great objective health but poor subjective health, or vice versa, where you have poor objective health but you have great subjective health? And I think that tells you a lot. And like you said, it's very relevant data, because ultimately, if we're thinking about human flourishing, we want people to not only be well, but they need to perceive themselves as well. I'm curious which of those two variants you would prefer to find yourself in. If you...
Yeah, I like to believe that everything is good with me.
In terms of methods, I think it's always interesting for me to read more of an economics or econometric paper, because although we both in epidemiology also do similar sets of modeling, we have different language, different methods, different approaches. In the methods, I was really looking out for sources of systemic validity bias. And bias has an unfortunate connotation in colloquial language where we assume it means invalid, but all data sets are biased to some extent. The question is how much and in what direction, and how do we use that to interpret the results? For me, one of the largest concerns about this question of self-reported health is that it's not in fact self-reported for the majority of respondents, right? It's reported by the head of the household, if I understood the methods correctly. And it would be interesting to see the descriptive data on head of the household respondent characteristics, especially by location. So for example, in North India, if the male head of the household responded on behalf of all the other household members, versus in South India, somebody else in the household was the primary respondent, and how that affects how you perceive a young child's health, how you perceive a woman's health, or severe menstrual pain will certainly vary depending on who's interpreting it. I think that to me would be great to see that if it was relatively uniform or that varied significantly by location. On modeling strategy, so I think there were some comments related to this, but a few questions and a few thoughts about modeling strategy. So in epidemiology, I'm used to sort of either predictive modeling versus causal modeling, and they're different approaches and they have different goals and different aims, and one can use either. In predictive modeling, of course, we're trying to build a parsimonious model that tries to explain the greatest amount of variation in the data set, right? So minimizing the log likelihood, improving the BIC. But it's not necessarily geared towards investigating a causal pathway between one exposure and one outcome. The advantages of that is, again, when you're describing, it's an appropriate approach, and it seems to be the approach what I would call you used. But the trade-off can be, so for example, I think somebody noted when you add location, a lot of the significant effects of other variables disappear. Part of that could be because location is an important confounder. Part of it is also when you add 102 more variables, of course, you improve model fit and explanation of the variation in the underlying data, but the cost of that is always precision. And it looks like the effects actually went towards null. It wasn't just an imprecision effect, but just something I think to consider and something that's a little bit different. And then I think it's absolutely fantastic, and I agree with Dr. Subramaniam, of adding a location and income effect measure modification interaction term. What I would wonder is, among your other covariates, your other variables, the pathway between everything you have measured and the outcome of self-reported health, what would your priors be in terms of those relationships, and what other interactions that we could expect that might be significant? So for example, one can also imagine a interaction term between gender and location, that in more egalitarian areas, HR regions, that gender and location may not have a large influence, but in less egalitarian areas, gender and location will have a differential influence. Same thing with religion or caste, could vary significantly and have an effect measure modification by location. The challenge is when you add more of these, do you have the underlying power? It's a very large data set, you may, but it's worth seeing what these interaction terms ultimately hold. And then finally, I think for some of the continuous data, particularly income, which I think is an important explanatory variable, your dose response, if you model only income alone, your dose response is predetermined by your model function. So you have already assumed that your income and self-reported health follow sort of a log plot, and that it'll be an S-shaped curve. Whereas really, I think in most health data I've seen, income usually follows more of a sort of a hockey stick. It's pretty linear until a certain point, at which point do you hit a plateau. I would love to see sort of raw income data and see if income might be better modeled by certain income categories is one way, or splines, or sometimes even polynomial terms. In terms of the results, so they're absolutely fascinating. And in addition to what sources of variation there are, for me as an epidemiologist, I think a lot about effect size and relative effect size. And location, income have decent effect sizes, but as you know, the single largest effect size was age. I mean, the variation in age from 1 to 30% is far, far greater than the variation in location, even when even in the fully adjusted model. The overall, I think location, I may be interpreting this differently. There's certainly differences in region and different variations, but the amount of variation in model 3, for example, in the way you've categorized it, at least, is relatively small. It's sort of 1% to 4%.
Yes.
So there's variations, but those variations pale in comparison to the size of variations of some of the other variables.
But as an epidemiologist, how is the effect size in age interesting? Because in a way, there's nothing you can do about it. I mean, age just is. So it's something you want to control. Right. I mean, as an epidemiologist, you should be saying to me, age is not interesting because I can't change it.
Yes, that's a great point. And that, yes, we're interested in modifiable factors. Age may not be modifiable, but interventions that address different sources of ill health at different ages are a potential intervention. We can't change age, but we can change the experience of age in many ways. And as you note, I mean, I think our national public health policy has been understandably focused on infant mortality, maternal mortality. But when you look at a comprehensive status of the health of the population and you see large sources of ill health, some of them are actually, you know, what in many other countries would be considered quite productive ages. You have to think about a different set of policy responses and interventions. And then last, I'll talk a little bit about the most interesting part, which is the discussion and interpretation. So I think it's really, really interesting that we note psychological filtering as a limitation, or you know, because I don't see that as something that's fixed. I see that as something that's dynamic, and to me, that's part of the outcome. You know, the ability, your psychological resilience is an aspect of health. And it is something that is buildable. It's something that's modifiable. It's something that is desirable. So I think that's not necessarily.
So actually, I was
part of the outcome.
I was discussing this with a friend who's a sociologist, and she was very supportive. She was the one that gave this flourishing perspective, which is in the paper. And she was saying, look, everything is a means to that end. At the end is that when we ask a person, are you feeling good today? The person should say, yeah, I'm feeling great today. You know, so everything is an input to that.
Absolutely. Absolutely. Oh, and that reminds me, in terms of the model building strategy, sorry, one of the potential sources of bias in predictive modeling is depending on your causal pathway. So for example, if age of the respondent is associated with income, and income is associated with self-reported health, if you control for income, which is an intermediate on the causal pathway, you can actually introduce bias at times. And so that's one of the downsides if you're trying to then use a predictive model to think about the causality of any one of the individual variables.
Yeah. The terminology I find convenient for this is survivorship bias. That this entire paper is ridden with survivorship bias because the rich live more, and that's just a confounder for all this work. They're around to answer the question, am I feeling good today?
Yeah. And then, you know, just in terms of going back to health and epi, so, you know, it's interesting, you know, where being rich does not improve self-reported health status. And a lot of that is in central India, Madhya Pradesh, Chhattisgarh. And you notice, you know, the availability of healthcare, having practiced for 2 years in rural Chhattisgarh, I will tell you that even if you're a rich patient, unless you go out of the state, the quality of private healthcare services is very poor. So even if you have wealth, the differential quality in healthcare that you can purchase with that wealth is fairly limited.
But how would you respond to what I was thinking, that hypothetically you are in rural Chhattisgarh and there is no healthcare at all? Then the rich should fare better because of the quality of housing stock and nutrition and a wee bit better knowledge. The health ought to be better. So what are we missing? Then would it just be, I think, survivorship bias that is tipping it over to the other side, that poor people tend to die?
I mean, it could be. It could also be that, you know, I think there's so many possible explanations, right? Everything from nutrition that you mentioned to just simply, I think, comparative psychology. If the more aware you are about possible states of health, the more aware you are of what is achievable and what you feel like you might lack, it could just be resilience and interpretation, because you know what you're missing. There's a lot of psychological accommodation to ill health that's well described in the literature. So one of the most famous examples is when you survey people and ask them, if you were to become quadriplegic tomorrow, lose control of your arms and legs, would life be worth be living? And 95% of people say no. And if you survey people who are actually quadriplegic and have been quadriplegic for a certain amount of time, 95% of them think their life has a lot of meaning and they would like to continue living. And so these, you know, these dynamic accommodations of our health status make it a real challenge, but are, you know, that's part of life and they're important. I think the other thing is, you know, you have in some of these poor, the so-called Bimaru states, you're still undergoing an epidemiological transition, but it's differential among the rich and poor. So in Kerala, you know, everyone's gone through the epidemiological transition. Nobody is dying of sort of preventable infectious disease, preventable deaths in childbirth, very few people. Whereas if you're poor in Chhattisgarh, you're still dying from undernutrition, starvation, infectious disease, snake bites, all kinds of very, very treatable, eminently treatable causes. But if you're rich, you're really just sort of, you've moved over to cancer, non-communicable diseases, heart attacks, strokes, obesity. And I think that is going to be very differential by location. And then, finally, one of the challenges of self-reported health is just that relates to the epidemiological transition is before you've transitioned and you're really dealing with acute disease, when you ask somebody how they're feeling today, that's likely to correlate better with their objective health status. If you have a fever, you're feeling unwell, but the fever is short-lived and it ends. If you have diabetes, for decades, potentially, you feel fine. You can have terrible diabetes and be eating rasgulla all day and be completely happy about your health until you get to the point of end-stage complications, but which is temporally a much shorter period compared to sort of the lead-in period for chronic diseases. And I think that has some interesting implications for the results. And then, finally, I just wanted to mention some references that might be interesting. So a different Dr. Subramanian about 10 years ago studied economic growth at the state level in health in India. I think this was published in PLOS Medicine. And the question is, does growth improve undernutrition? And the answer was no. Economic growth across different states in India was not associated with improvements in undernutrition until there were specific undernutrition related interventions taken. But overall improvements in income and wealth did not improve childhood undernutrition. A similar paper, does being wealthier make you happier, looked at, make you healthier, sorry. Sanjay Basu, who's an epidemiology colleague of mine at Stanford, he looked at Latin America, 20 years of growth across different countries, and wealthier was healthier only when inequity was low or improving. But wealth in the absence of, in the presence of high inequity or worsening or stagnant inequity was not associated with improvements in health. He used objective health measures. So that was going to be, in terms of future research, one of my recommendations is not only looking at income, but looking at income distribution, perhaps a location-based Gini coefficient, and seeing how that modifies self-reported health. So one can imagine if you live in a poor village and everyone is poor, your relative perception of your own health depends on, we're human, we're all status seekers, and your relative perception of your health depends on your neighbor's health. But if you live in a highly
or Stigler-Cost disease, that doctors will always be the top 5% of the income distribution. And so the distance of the doctor's income from the income of the people will generate access to healthcare.
Yeah.
In a more equal population, the doctor's price point is more accessible to a large chunk of.
Yeah, absolutely. Absolutely. So it could be exactly related to service availability. Inequity could be related to service availability, as well as sort of the psychological aspects of perceptions of self-health, depending on how you who you're comparing to.
Sorry, I said Stigler-Cost disease. That is not correct. It's Baumann-Cost disease. Yeah.
Okay, I haven't heard that term. So Baumann's I've heard. So that's it. I think I had those are my main takeaways. But overall, I think a fascinating start for much deeper dives.
Thanks, Naman. This is your thoughts are very interesting. I'll request you to take photographs of your notes and email them to me. The trade-off and the question in designing this paper is, what's a compact and coherent paper? Because actually there are 25 directions in which one can go off to, and some of them indeed belong in this paper, and maybe some of them should be done downstream as many other projects. So we just wanted to do a main first paper which establishes some interesting and important facts, And then there are innumerable downstream research projects that can and should be done. And, they don't all have to be in one monster paper. We think science makes progress one small paper at a time.
Completely agree. And I think what would help myself and perhaps many others on this call in planning for those downstream papers to work with you or to take next steps is to look at some of the raw distributions of the data, which of course we can do with the data set directly. But if you've already done some of those, in addition to the modeling tables, some additional descriptive tables and distributions of at least the key variables would be, I think, really helpful to understand.
Okay, so I've written down notes from some of this, and I'll talk with you further on these incremental modifications. Mahesh, what are your thoughts on how we should handle ourselves for the rest of this time?
So, Ajay, we have 15 questions from the audience.
Okay, should I dive into them myself?
Yes.
Okay, Sadekul Islam, do you have data on life expectancy and mortality rate across income quantiles? This is important for understanding health inequity. In the CMI CPHS, you will see that same individual again and again across waves. And when the person dies, CMI records it and shows it to you as a flag saying this person died. So you don't get life expectancy, but you get death events on a per person basis. And so it's possible for the first time in India to build large scale papers with mortality of people on the left-hand side. My colleagues and I are right now doing one such paper. At the beginning of this seminar, Mahesh mentioned that we were able to imagine how to use this data to measure excess mortality in the pandemic. Okay, so there's a whole array of interesting research on death, which can flow from this data set. The construction of life expectancy is a statistics question to be applied to this data set. Okay, now I'm just briefly, oh yeah, that went off because somebody pushed it off. Yeah, I got confused because I couldn't see it anymore. Okay, Smriti Balsari says, does not feeling well include mental health or just physical health? A lot of people feel down. You're absolutely right. And Naman also emphasized that there is an inexorable role for psychological factors, potentially for mental health, in the mapping from objective health status to reported subjective health status. And one more layer, as Naman correctly emphasized, is the problem that the CMI CPHS implementation involves meeting one person per household and asking that person, is person X in your household feeling good today? And that's different from asking that person, is she feeling well today? So we need to be careful in the use of this data and the interpretation. And Mahesh, we need more facts about the respondent, because, for example, male respondent versus female respondent, these are very important things that require further chasing down. Okay, next.
So you're suggesting, before you go there, Ajay, so you're suggesting, see, we don't release the identity of the respondent in the database.
Yeah.
So if we reveal that in the database, that of the member IDs, this is the person who responded on behalf of the entire household, we can do that. But let me just clarify a little over here. It is relevant that the main respondent is not necessarily answering the questions unilaterally. We encourage the person to consult others before the person responds. So it's quite likely that one person asks the other person, how are you feeling today? Or may answer, because the person is sick, you say he's sick. So the likelihood of ill health being reported, like clear ill health being reported, is very high. But the likelihood of subdued ill health being reported may be a little lower. And in this respect, asking questions to each person becomes more important if you're asking questions on mental health. Because mental health, about depression, etc., you better answer yourself, kind of thing.
We don't disagree on the measurement strategy. It is cumbersome to ask each person of each household. But if we knew more about the respondent, for example, straight away, male respondent versus female respondent is so interesting.
So yes, so point taken. We will take this seriously. We will also release the information of the respondent ID in the coming waves. Yeah. But note, this is not a unilateral answer regarding from the respondent. That clarification. Okay, you can go to the next.
Okay. Smriti Balsari says, sorry, I finished Smriti Balsari. Next, Sadiqul Islam. I'm surprised to know that the probability of ill health is higher in South Kerala, which is known for a good quality healthcare system. Yes, the CMI CPHS data is filled with surprises. A lot of what we think we know, we have to revise our priors because we're seeing evidence for the first time. Kalyan Kuluri says, how do you empirically conduct conditional ill health estimates? How is the model regression set up? It's just a logit. So on the left-hand side is a 0, 1, which is, are you feeling good today or not? And on the right-hand side is a bunch of individual characteristics or household characteristics, which are all from the CMI database. When you say the modal regression setup, maybe I have failed to communicate correctly. In the paper, we talk about the modal person. So we fixed some characteristics as a person age 34, 13,000 rupees per month household income, rural, male, SC, and so on. So all those are the numerical values for the right-hand side variables, which are plugged into the estimated widget. Okay, next, Smriti Bulsari says, don't you think that the HR random effects would have been more interesting because the characteristics of the HR that influence health are not known? Okay, so I think that if I'm doing y to a plus bx, and I'm really interested in the coefficient of x, and the panel variation is just a nuisance, I need to control for it, but for the rest, I'm not interested in the numerical values of that panel variation, then I want to a random effects model. So I want to control for that variation, but for the rest, I'm not particularly interested in the nature of that variation. Here, we are on the hunt for that map. We care deeply about the numerical values of those coefs. So that is why, we felt fixed effects is a nice way to go about it, because it gives us numerical values for those 102 coefficients on health, 102 coefficients on income. And those were the maps that we wanted to draw. It is indeed interesting to bring the standard linear mixed effects type machinery, the nonlinear mixed effects machinery into this paper, and that will give you a different set of papers. I entirely encourage mixed effects people to apply their worldview into this data set, but it would be a different set of questions compared to what we have done. Paul Katuman, hello, how are you? Says, it would be interesting to know whether one reason why some variables, for example, religion, lose significance when the HR fixed effects are included might be that the dispersion for such variables is low within HRs. Most of the variation is between HRs. It's a fair point. Trying to think. Your question is correct. I'm trying to think about numerical examples. I think these are such macro covariates that there's really variation on these everywhere. Let's talk about them. Gender becomes weaker, no problem, 50-50. Religion, I think there are HRs in India where there are very low number of Muslims. So that could be an issue. Interestingly, the Muslim coefficient does not change a whole lot. It's the Christian coefficient that's driving it. That's the other. So it could well be the phenomenon that you are describing. In caste, I think there is a decent distribution everywhere in the country. In education, I think there's a decent distribution everywhere in the country. So I think your idea is a good one. And I think it helps explain why religion other goes away, because there are many HRs in India where the number of Christians is negligible. So I think it's a great idea. You're correct. And we should do that more. An anonymous attendee, show us your name, says, hi, thank you for the insightful presentation. Since 2 waves, 12 months start 2, are used, what is the temporal variation in the self-reported health? 6 waves are used because CMI does 3 waves every year. So this is a data set covering 2 years, 6 waves are used. We did not pay attention to the temporal variation in self-reported health rate in this period. My recollection is it doesn't move a whole lot. I wish I knew it by heart, but there was not a lot of action. Okay, Rajesh Kumar says,
if I can add, sorry, just certain locations, having been a malariologist for a long time, one of the most common causes of ill health would be fever. And in highly malarious areas, for example, right, there's a huge temporal trend to fever rates. But I think overall, there's so many other aspects of ill health that I would guess that it probably gets drowned out.
So on a related note, we had done extensive field work in UP. We were working on some audit of government hospitals in UP, and through conversations with doctors, we got this idea from them that in the monsoon, there's flooding of many a household, and there's fecal matter contaminating people, and there's a lot of sickness that happens during the rains. We went into the CMI database and looked for this phenomenon, and it's not there. Okay, so probably there's so many other things going on that this thing is not being picked up in isolation. Rajesh Kumar says, interesting data and analysis, a delight for the epidemiologist. Would like to read the paper and see what more can be done. Yes, please. We have, I think the URL for our paper has been distributed. We're very happy to discuss with you further. Please write me email, and would love to talk with you more about ideas, about collaboration and so on. Arpin Sinha says, interesting analysis at macro level. Does CMI think plan for a causal explanation with micro studies, without which it has limited use? I would stoutly argue that descriptive papers are incredibly useful. Okay, John Snow's cholera paper was a descriptive paper, so we should proudly do descriptive work. And it is perfectly feasible to use a subset of the CMI database for more micro studies. For example, my co-authors and I have a paper on the Chennai floods. We just used the CMI measured households in Chennai, and we treated those as treated households where they have experienced a flood. We matched them against similar households from neighboring districts where there was no flood, and hey, you get a very interesting micro study. So you can always drill down into a subset of the 170,000 households and do a micro study. Similarly, just today while talking, I said the favorite instrumental variable of every development economist, namely rainfall IV, is perfectly usable here. You could definitely look at SRH and rainfall IV. We've just left this for the next person who wants to write a paper on this. Okay, A.B. Abraham says, is it possible that meaning of feeling good or healthy varies across HR based on the cultural ideas? First, I would say yes, surely it may be the case. But then I want to take you back to some of the maps. You remember I pointed to a chunk of Haryana where the westernmost part of Haryana has a lot more ill health than the rest of Haryana, and as compared to Punjab. These kinds of phenomena. Think Kerala, North Kerala, Middle Kerala, South Kerala. Think Andhra Pradesh and Telangana. The variation within these states makes me think that there is actually a lot going on under conditions which sociologists would call relatively homogeneous. So I'm not so ready to tell a cultural and a sociological story about the notion of feeling good varying by state, because we're seeing things happening intra-state in this data, which begs the explanation. Paul Kattuman says, once again, Kerala's poor health, in the light of admittedly anecdotal evidence of almost excessive propensity to consult doctors. Now I agree completely with your anecdotes. Raises the question of whether it might be useful to benchmark whether their SRH scores are better or worse than in the last wave. All in this data set, we see the same individual wave after wave, and we see what is their SRH score. What you could do is imagine a paper could be done where a person gets sick and they use healthcare versus they don't. Because if they use healthcare, there will be a surge in the healthcare expenditures, which are measured in the CPHS database. So that would be another nice paper idea, that does turning to a healthcare provider help or make things worse? And all of us will be very interested in that paper. Rajshri Vedamatta says, it will be interesting to know what are the gender variations of self-reported health in different HRs. Are there any findings? Northeast, which historically has shown low self-reported morbidity, comes up very high reporting in the CPHS data. I actually did not know that there is low self-reported morbidity in the Northeast. Can you please talk to me separately about this? It is my lack of knowledge. I did not know that there were these data sets. Gender has not proved to be an exciting variable in this data set. So we went in with this preconception that maybe women will report higher ill health rates, but it's just not there in this data. And two of my co-authors are women, and they blame the male respondent who talks to CMI. Matthew George says, thank you, Ajay, for that crisp presentation. How would you like to engage with the perception factor critique that I believe Amartya Sen raises as a critique to self-reported morbidity during the 1990s? And related to that is the role of medicalization in states like Kerala of already reporting greater morbidity not only amongst elderly, but across the age groups. So I am not excited about Amartya Sen's arguments in this field. First is in the international literature, self-reported health has delivered. Okay, so we have really done hard work on the literature survey of this field, and all across the world, poor countries, rich countries, self-reported health has meaning. There are papers that just triangulate between self-reported health and objective health measures. It works. So I'm not as ready to dismiss this as Amartya Sen is. And self-reported health is orthogonal to the question of medicalization. Self-reported health is just asking the question, are you feeling good today? Whether you choose to go to a doctor or not is a separate story. Okay, so I think that's itself a separate downstream line of inquiry, that some people report SRH equal to 1. Of them, some generate healthcare expenses, some don't. Okay, and those are all interesting research questions that we should be pursuing in this data. Yes, Naman?
Mahesh has had his hand up first.
Yeah, sorry. Naman, you can go ahead. I can come in afterwards.
Okay. No, I was saying, I'm not sure where this notion of Amartya Sen critiquing self-reported health comes from. My reading of his papers, and the one I'm thinking of specifically, is positional objectivity, sort of the classic Bayesian explanation. He used examples from Kerala, and in fact makes the argument that, you know, subjective health matters, in fact, because, you know, the reality of health, it depends on the position of the observer. And that should be our prior. I mean, you know, we should think that location really matters unless proven otherwise, based on life experiences. I mean, if you live in a swamp versus if you live on a cool mountaintop, right? If you live where there's good weather versus if you live where it's dark and rainy all the time, you know, there's seasonal affective depression. Our prior should be that health location absolutely has effects on health. And that also subjective health really varies depending on the circumstances of the individual. And I think what this research does is, at least in terms of groups of individuals, what are those circumstances?
Yeah, Mahesh, you were saying something?
So I'd like to add only one thing regarding this perception regarding self-reported health. What we are asking is, how are you feeling today? Are you feeling ill or are you not feeling ill? Now, you may not be feeling ill because you're on medication. Suppose you are a person who has got, you know, hypertension, but you take your medicines regularly. So you are not feeling ill because you are on medication. You could be diabetic. Now, we need to understand this self-reported health. It's a feeling of feeling healthy. You could be feeling healthy after taking medicines. So there's an additional question which we have, which probably can be exploited as well. You are feeling healthy and you are on medication, or you're feeling healthy and you're not on medication. Maybe this angle could throw a little more light. And what do people like, you know, other researchers talk in terms of what is self-reported health, used with facts from medical records. Your medical records may show you as a person who requires health attention because you're diabetic, for example. But if you're taking medication, you'll report yourself as healthy. So just making the distinction between on medication and healthy and not on medication and healthy are a little different.
And they're all fascinating and important avenues for research. So, you know, we as a research community need to organize ourselves to go after all this. Anonymous attendee says caste, location, poverty ratios, and location will be interesting to explore. Yes, but we drilled a lot into caste, and there's just not a lot going on there. But you know, I'm sure there are others who know more than us about caste. Pallavi Vyas, is this Pallavi Vyas from Ahmedabad University? Hi. In rural, peri-urban areas, the higher income quintile individuals may not be as highly educated as in the urban areas. Can the income variable interact with the education predict health better? It's a great question. Okay, there's a paper waiting to be written there. How is an HR defined? Does it overlap with districts? An HR is a group of geographically contiguous districts that have similar values of agroclimatic conditions, women's literacy. Is that correct, Mahesh? What else?
Yes. And urbanization.
And urbanization. So HRs are a new collection of partitions that add up to India. And CMIE does sampling at the level of each of the HRs. The sample sizes are chosen and the sampling is done in a way that permits us to make statements at the level of the HR. Pritik Zanwar says, is this a longitudinal versus cross-sectional data? It's longitudinal data. But in this paper, we don't exploit that. This paper is just doing simple analysis of the data without exploiting the panel character, but the data set is longitudinal data. 2, age increases prevalence of chronic conditions, and wondering if top conditions in India are available. Not in this data set. In this data set, we know nothing else about the nature of the malady of the person, other than the fact the person says, I'm not feeling good today, or the person says, I am on medications today. And at the household level, we see monthly data for healthcare expenses classified into prescription drugs or hospitalization or consultations. Mahesh, is that correct?
That's right.
Okay. 3, income, education, and occupation are correlated and affect overall health. Would be worth include education, and this may vary. We do have education in this model. So we do income, education, and age and location in this paper. We don't do occupation. CMI has a very rich measurement of occupation. That's a separate line of attack. Pallavi, you should be looking at CMI occupation variables, but in this paper, we are not exploiting that. Suryakant Yadav, does this data set report on causes of death at individual level? No. What you just see is that we are watching the same person wave after wave. One fine day, that person dies. In the next wave, the record says this person died. That's it. We don't know why the person died. We don't know the date on which the person died.
If I may, sorry, just briefly on causes of death for the members of the audience. If you're interested in cause of death survey data, the Registrar General of India, through the sample registration scheme, does do cause of death data. And Prabhat Jha from the University of Toronto has been doing sort of the million death study using verbal autopsies for cause of death. Really briefly, one of the most interesting projects I did about 15 years ago in Jalpaiguri in North Bengal was a household survey with self-reported cause of death, which I think is also interesting compared to objective cause of death, just like self-reported health compared to objective health.
Pritik Zanwar says culture, unique to each state, climate, air pollution, other factors may affect health, and wondering if such variable is available. Well, you have to construct it. So you have to use satellite data, create a measure of air quality in each HR, peak temperatures, heat waves in each HR, and then you can come and re-examine this SRH, and that's definitely a paper opportunity that's waiting to be done. Kea Mello Furtado is saying, have you compared your findings with the NSS 75th round? We have done so superficially in the textual description. So we've done our fair share of comparison in the paper, but you can't push the comparison too much because the two data sets are profoundly different. Shashi Lata Yadav says, do you have data on clients and doctors and nurses' perception on provisioning of healthcare services in selected states of India? Not in this data set. This data set is only about the households, not about the healthcare business. Yes, Mahesh, I'm done.
There's one last one again on NSS. So Ajay, do you have a response to that? The 42nd, 61st, 75th rounds all show very low reported morbidity for Northeast. Very last question.
Okay. Yes, I see Rajshri Padamata. Can you please talk with us separately? You are clearly ahead of us on your knowledge of the Northeast. No, I don't know what is there in these NSSO rounds. I have not studied NSSO data myself. I only read papers written by other people using NSSO. So in short, I don't know this and would love to talk with you further.
Okay. You have answered all those questions in rapid fire format. But thank you everyone for the audience for putting across wonderful questions, and thank you Ajay for answering all of them reasonably well, reasonably quickly. We are now at 8:52 India time. We have more or less covered the time that we had allocated for this. Your presentation was crisp. Naman had a string of points to make. You responded to most of them, and to all the questions in the audience. we will be happy to connect Ajay and Naman, if you would like to, with all the people who have raised the questions. We can pass them on to you. You can connect with each other as well. We'll be happy to organize that. And if anyone of you would like to connect with Ajay, you can make a request and we can put you in touch with him for all your academic interest in this paper. So with that, we can bring this session to an end. I will just make an announcement before we close this session that the next Consumer Pyramids research webinar is on March 3rd. So it's an interesting paper by Anup Malani on income inequality. So please feel happy to come to that and participate exactly like we participated over here. And with that, thank you, Ajay, for a wonderful presentation. And thank you, Naman, for an excellent discussion on the paper. And thank you for being awake so early in the morning and participating in this. Thank you, all the audience that was here to participate in this. Thank you. We can bring this to an end now.
Thank you, Mahesh, for building a great database.
Thank you.
Yes, absolutely.